Hi, good evening, everyone. Welcome to tonight's panel discussion, which is a follow-up session from the one we had a few weeks ago on the topic of suicide, which was an intersectional dialogue amongst people from various perspectives. It's really encouraging to see almost 100 people join us on this Tuesday evening to discuss what is often seen as a very somber topic, but one that I think requires many more urgent conversations such as the one that we've had in the last couple of weeks. I'm very encouraged by the good and high response that we've had to this series. And I know many of you might have attended the first one, in which we've heard extensively from our panelists. And I made a promise that I was unable to keep when I did the first webinar, which was that I will provide as much time as possible for questions and engagement. And for me, that's always the highlight of attending any kind of online discussion. And unfortunately, I did not stick to the promise that I made, because we firstly had many panelists and we had such rich dialogue amongst the panelists. And judging from the chat room discussion that was going on the last time, most of the audience members were really engaging quite well with that. And so rather than cutting the panelists short, we thought it would be better rather to have a completely separate follow-up discussion where we can almost exclusively have dialogue between the attendees and between the panelists themselves. So thank you everybody for attending this follow-up session. And we hope that the next 90 minutes together will be stimulating, that it'll open up space for critical dialogue and discussion. It will allow us to ask some difficult questions, both of each other, but also of a topic that is often very contested and difficult to grapple with, both from a research perspective, a clinical perspective, but also a lived experience perspective. So we're hoping tonight that we are able, similarly to the other week, open up multiple viewpoints on the topic of suicide. Good evening, everyone. My name is Santosh Pillay, and I'm not going to do a whole introduction of myself or the panelists all over again. But suffice to say, for those who haven't met me, I'm a clinical psychologist based in Durban, and I work at King Dinizulu Hospital, and I will be facilitating the panel discussion and the questions and answers today. I'm going to just allow each of the panel members that are with us to just briefly say who they are again, just as a reminder for those of you who've been with us before, but also for those of you who are joining for the first time, just to get a sense of who's in the room. So Cassie, I'll start with you.
Good evening, and thanks again for PsySSA for welcoming us back and allowing us to have the conversation. My name is Cassie Chambers, and I'm the Operations Director at the South African Depression and Anxiety Group. Good evening, and thanks to everyone who's joining.
Thanks so much, Cassie. Great to have you back. Glynis, you can go up next.
Thanks so much, Santosh. Wonderful to have this platform to speak on this very important topic. Glynis Horning. I'm a freelance writer, journalist, and I've written a book called Waterboy, Making Sense of My Son's Suicide.
Thank you, Glynis. Great to have you back as well. I noticed that we don't have Saya with us, who had spoken the last time, both from her perspective, also as a writer and journalist, but also from her own lived experience of, as she termed it, experimenting with suicide. But I think Saya might be joining us a little bit late. And when she does, I'll give her a chance just to introduce herself again. I also see that Dr. Sebo Siepe, who was the president of the South African Society of Psychiatrists, is also running a bit late, but she might join us a little bit later this evening. I also want to introduce Rebecca Hellman, who was not on the original panel, but gave us some very valuable feedback based on her experience of being an audience member in the last panel. And given her work on suicide that she's currently engaged with, we thought it would really be prudent not just to have her ask some of the tricky questions that she asked of us after the webinar from the audience, but actually to include her as a panelist again this evening. So Rebecca, I'm really glad to have had the email engagement with you, and thank you for taking up the invitation to join us today, because you're doing some amazing work on suicide, and I'm really excited to hear more about it. If you don't mind introducing yourself, and I'll give you more than just 1 or 2 lines, so feel free to tell us a little bit more about the work that you're doing before we kind of get going with the webinar itself.
Thanks very much, Santosh, and yeah, thanks to PsySSA for having me. So I guess I would say that I'm a social psychologist, and I'm currently working on a project about suicide that's actually based in Scotland, but I completed my PhD at UNISA, and my previous work has been in South Africa, both as a researcher and as a counsellor. And so I've sort of interacted with suicide in a variety of different spaces. But really my current work is not from a sort of strictly sort of psychological perspective in the way that we might traditionally think about that, but it's really looking to develop more critical and sort of contextually situated understandings of suicide. So that's really the perspective that I'm sort of coming with. And I guess that's where some of my discomfort about the previous discussion sort of came from, that I felt that was sort of missing. So that's sort of what I'm going to be bringing to the sort of panelists, but hopefully to the audience as well, just some questions about how maybe we can think differently or beyond some of the ways that we are sort of normally thinking about suicide.
Thanks so much, Rebecca. Really looking forward to hearing your perspectives as well. Just some housekeeping for the attendees. So those of you who arrived a few minutes late, welcome again. This is an engagement session. So we are wanting to hear as many voices, as many opinions, as many perspectives, as many contributions, reflections, etc. as possible. So we're going to do it in multiple ways. So first, I'm going to ask Rebecca to offer a couple of comments and critical points of view that she's had, which is the reason we invited her on. I'll allow the panelists to have a little bit of discussion amongst themselves if they want. And then we'll take questions from the audience in many ways. So you can either just turn on your mic and leave your camera off if you want, and just offer a question or a reflection or a comment. Or you can turn your camera on and your mic, and we can just see who you are, and you can do the same. Or if you want, there is the chat box and there's the Q&A box. So there's multiple media in which you can offer a contribution. And I trust that Mohammed is in the background at the PsySSA office, will assist me with some of the background facilitation just to ensure that we get through as many people as possible. I know just from scrolling through the attendees list that there is a wealth of knowledge, experience, from multiple perspectives that are here today. So I know many of you who've joined in are certainly not kind of naive to the topic of suicide, and yourselves are heavily involved in this work from a clinical perspective or a research perspective, etc. So please feel free to also offer your own perspectives, even if it's not a question in particular. And I'll be as studious as I can and try to finish on the dot of 7:30, because it is a Tuesday evening. And I'm sure people have families to go back to and suppers to cook or eat. Those of us in KZN are dealing with torrential rains in the background. And of course, on top of all of that, we have load shedding. So I know that this entire important discussion is happening in the context of many other things that are going on in life as well. So without any further ado, Rebecca, I'm going to open up the space to you, because without giving away too much, I mean, you sent us quite a challenging email, but one that we almost immediately agreed with, because you felt that there wasn't a critical enough perspective from a, I suppose, social and political point of view in terms of how we grappled with the topic in the first webinar. And, you know, I think my first response to you was, yeah, absolutely. You know, we can't talk about suicide in an overly individualistic, overly psychologized manner, because it certainly does not do justice to a topic such as that, both from a lived experience, but also just from a kind of discourse perspective. And so I was really glad to get your message, and I'm hoping that you will bring that perspective into the room today, and I'm hoping that it'll open up different avenues for us to actually engage with the topic. So Rebecca, over to you.
Thanks, Santosh. Yeah, just as you were sharing, I had some sort of reflections, and I thought, you know, what should I do with this? I feel sort of quite frustrated, a bit distressed, and a bit disappointed. So I decided, yeah, to reach out to PsySSA, and it was, I think it was a really positive response to have that. It's always difficult to be the critical person in the room that is, you know, bringing something. And so I guess that my sort of disappointment, I was really excited to see the discussion, and particularly that it was bringing together sort of different perspectives. But I sort of walked away feeling that the session was really dominated by quite a narrow and sort of medicalized, and as you've said, sort of individualized understanding of suicide. And there was lots of talking about sort of signs we need to look out for, how to medicate people who are distressed. Cassie obviously spoke about the great work that they do, but that's really a sort of crisis intervention rather than sort of prevention work. And then also quite concerningly, yeah, this idea that we should be, the way to respond to suicide is by surveilling people, our family members that we think, you know, might be distressed, and that if we don't catch those signs, that that's somehow sort of a failure. And of course, you know, that kind of discussion is not only happening here, it's not only being produced by psychologists and psychiatrists and other people, you know, only in the South African context, but I think this is really a central way in how suicide is thought about and responded to across the globe. And of course, what this kind of approach really fails to do is to contextualize people's distress. I mean, I think it's interesting what you're talking about now, you know, the torrential rains, the load shedding, that is the reality that people are living in South Africa. And so I guess I wanted to, you know, ask a couple of hopefully disruptive questions, you know, to the panel, but maybe to the audience. And of course, people don't have to respond, but I hope that this will perhaps catalyze maybe a different way of thinking. So my first question is, how can we talk about, you know, mental health and suicide in particular in South Africa without centering issues of inequality and injustice? And this does not mean mentioning sort of social determinants of health as one of the factors that contributes, or making reference to the fact that, for example, people who live in Manenberg may be experiencing some kind of social distress, but really reframing suicide as a social and political issue, which is produced by various kinds of social injustice and social inequality, and therefore which demands sort of social and political rather than merely individual responses. And so to follow on from that, what would it mean to shift from thinking about suicide as a mental health problem caused by depression to thinking about it as an expected and actually reasonable response to the conditions under which many people in our country are living? And I was just thinking about what Cassie was saying about in the pandemic, about how many more calls people are getting because of COVID. And we know that that's related to and just intensifying various kinds of social inequality and people's sort of desperation. And so how can we think about the way in which medicalized understandings of suicide and distress may in fact normalize social contexts which make life unlivable for many people? And instead of this, how could we create sort of psychopolitical approaches which make connections between social inequalities and injustices and the emotional impacts that these have on people's lives, one of which may be sort of suicidal distress? And then just finally, how can we think about shifting from individual to more collective efforts to repair ongoing social injustices? And how can we think about that as the work of suicide prevention rather than some of the other things that were happening in the original discussion?
Thanks, Rebecca. I think it raises some important issues. And as you were talking, I mean, I was thinking immediately of like work by China Mills, for example, and her book, Decolonizing Global Mental Health. And I think I read the book quite a while ago, but she starts off with talking about, for example, the spate of suicides amongst farmers in India during particularly difficult agricultural periods where they were unable to earn an income. And what was really interesting, if memory serves correct, was how the suicide letters by the farmers were addressed to the government, not to any particular individual in their family or in the immediate context. And I'm wondering whether when you talk about kind of psychopolitical approaches, and obviously political doesn't mean party political, you know, you're obviously talking about kind of power structures. But when we think about how power structures like government or like failure to provide consistent housing or electricity supply or those kinds of things actually can increase the rate of suicide. And when we think of interventions that then speak to these major kind of structural issues, on the one hand, it seems obvious, but on the other hand, it can almost seem a bit kind of overwhelming because I would almost say not almost always, but a lot of the time, many of these structural issues are then exacerbated by maybe a failure of people to get support within their individual environment. So I think my question to you then would be, how do we kind of strike this balance between almost, I would say, individualized distress because there's failures in the immediate environment to offer support, and also this like large scale structural issues that almost none of us would have the power to immediately resolve. So is there a balance, or how do we strike the balance?
Yeah, Santosh, I think that's a really important question. And I would not for a second deny that the kind of work that Cassie does and the kind of support that perhaps Glynis and perhaps her son as well was accessing, that is not important. But I think that we are locating the way we think about suicide too much in that approach, and we're, all our resources are being pooled into developing those kind of interventions, and what we're not doing is stopping the same number of people who need those services all the time. So I think that this is really difficult work, and it's not only about thinking about sort of social inequality in relation to poverty, but we can think about how young middle-class people are finding their lives very distressing because of the collapse of global capitalism. And that's quite difficult to think about what suicide prevention in that case might look like. But that doesn't mean that we shouldn't think about it, and we shouldn't be engaging with that, and we shouldn't be, spending our personal, emotional, and political energy lobbying for other kinds of suicide prevention, including access to housing, including access to water, including access to physical health care, and mental health care at the same time. And just because you mentioned China Mills, there's also some writing about the UK, and because that's the context where I'm currently based, and in migration in relation to Theresa May's policy around hostile environments. And I really like that way of thinking about social context, that really China Mills argues sort of invite and incite people to die because they are hostile to living. And I think that we can see, perhaps not in the same way in South Africa, not that they've been necessarily directly engineered by the political parties, but that there has been a failure to respond to the conditions that make life unlivable for so many people. And so we should be horrified, but we shouldn't be surprised that there are so many people calling this crisis, these crisis lines and dying by suicide because, that they feel that is a preferable option to living in constant distress and just instability.
Yeah, absolutely. I already see there's some comments and questions for you, Rebecca, that's been generated in the chat. So perhaps you can get to that on your own accord if you want. And I want to just bring Cassie in to just respond to some of those points, because Cassie, the crisis line is kind of at the coalface of people actually, I would say, on the edge, and people phone you often as a last resort. So on the one hand, it is that kind of crisis work, and almost necessarily by design, a helpline has to work with the individual. But I also know that, SADC does some other great work that is preventative, such as, school talks, etc. But Cassie, from an NGO perspective, I mean, how do you kind of respond to maybe some of the critique that some of the focus around suicide prevention is overly individualized, and that we tend to ignore the kind of structures in society that's causing unlivable lives, as Rebecca says?
No. Thank you so much. And Rebecca, I'm so thrilled that you're part of this conversation, because I think we have to disrupt the way that we see suicide prevention, promotion, and intervention. And I think even this conversation that we're having now is probably fueled from the recent couple of weeks where we've seen suicide in the press and media, right? And we often respond to what we're seeing by having these kinds of conversations, which is both important. But again, these kinds of important conversations should be happening throughout the year, because we know that suicide is a huge issue. I hate having to see South Africa hit all those top ranked, suicide is more severe in South Africa than the UK or the US. And the WHO says, living in South Africa has the most unhappiest people. And we're topping those kinds of ranks and those lists around the world. And I think we have to disrupt the way that we think and view suicide. and especially suicide prevention. So I'm really thrilled that Rebecca is here and that we can start to really have these kinds of conversations. And I think also sharing what you see on the coalface of having a crisis line, that's a tip in the ice, tip in the ocean, drop in the ocean of what the real issues are on the ground. Again, talking about inequality, the people that hear about SADAG or reach out to us are people who have resources. They have a phone, they've seen us being advertised on TV, maybe they saw a poster up, they heard about us. So they're reaching out and contacting us. There are still so many more people on the ground that don't know about us or don't know where to go or don't know how to access help. We know from research from Professor Crickland and his team at UCT that only 1 in 10 South Africans with a mental health issue have access to treatment. It means 9 out of 10 people don't. And I think one of the things that we at SADAG, we've been asking these questions to ourselves and our teams and the way that we've been doing work during COVID is everyone went home, everything went online, and all of a sudden, the only people we could access were people through webinars, through social media, through people who had resources. And people on the ground and in communities who were dealing with the impact of COVID the most, we couldn't access and we couldn't reach as we normally did door to door. So I really think it's an important conversation, and still keeping that individual view, which I think helps us, especially in our NGO and on the crisis lines, to keep coming back. It's kind of coming back to that starfish model of the little girl walking along the beach, and this guy finds her throwing these starfish back into the ocean, and he says, but why are you doing that? There's so many starfish, you're never going to be able to save them all. And she says, but maybe for this starfish I'll be able to help. And I think as a volunteer and working in the front line that we do, that one starfish at a time helps to motivate us. But looking from a strategic advocacy group as SADAG, we have to look at it from a collective. Is that some of the cases, and especially with COVID, but these were happening way before COVID, is I just think of a case we had of a mom who's calling in who has nowhere to stay. She's got 2 children. They haven't eaten for a couple of days. They've got no family, no friends, no totally terrible situation. And her option and thought at that stage is that there is no solution. There is no hope. And maybe we are better off in killing my children and myself. And we all think, no, that you can't possibly do that. But if we look back and think, well, the system has failed her and we don't have the support in place and we can't fix all these different socioeconomic issues. And that for her, perhaps that is the only solution for the ongoing suffering. And we have hundreds of those cases every single day. And I think it's having to look really in a collective view is to say, like, we have to do something different. SADAG's been around for over 28 years. We run the suicide crisis line. We know that the calls are increasing. But through all this created awareness, and we're doing campaigns and we're going into schools to do prevention, is we're not seeing the kind of change and difference that we should be seeing after so long. And I think this is why having someone like Rebecca and so many other people who are asking questions now is we have to critically look at the way that we adopt this. And we are having this conversation, but this table should be including government, the people that are putting the systems in place, who are putting the policies, who are pulling budgets. We need to have all of these stakeholders around the table so that we can have a collective approach to dealing with suicide. When I'm dealing with different clinics and hospitals, and in the last couple of weeks, just really looking at the state of mental health and dealing with long waiting lists, even with us as a crisis center, we can contain you in a phone call. And then when we're having to implement the system and referring you to a hospital, getting someone admitted, I have hospitals that have a 95 patient waiting list. We have clinics where you can only see a psychologist maybe once every 3 months. Those kinds of systems that we should be having on paper are not happening on the ground. South Africa has a very poor community mental health system. So we are, that revolving door syndrome, that parasuicide symptoms that we're dealing with on a day-to-day needs a huge disruption. And I think it's about having those critical conversations because we're at the precipice of we have to do something better. Otherwise, SADAG is going to have to get bigger and bigger, more helplines, more counseling. but we're not seeing the changes on the ground. And I think that's what's the most difficult. And talking about inequality, mental health is not seen as a real issue. It's not prioritized. It's not, the budget doesn't follow. We're seeing less beds, less professionals, less psychology students getting into I mean, the need for mental health is huge. We have all the stats, we've created the awareness, we're screaming on all the soapboxes that we can. Something more has to be done because we're seeing this getting worse and worse every day. I think one of the two last things, because this I could probably talk on all night. I think one of the things that South Africa needs to look at differently is when we say it's a mental health crisis. You know, we're often in all of our responses and activities, it's often reactive. We have a celebrity who dies by suicide, or a school has lost a student to suicide, and then they're reaching out to us to come and do a talk on suicide prevention. That's crisis intervention. It's not prevention or promotion of mental health. When we're looking at how poverty is increasing, unemployment is increasing, and of course that has a direct impact on mental health, not just during COVID, is we're not seeing the interventions and the systems in place to actually fix that in order to lessen the strain and the impact and the burden on so many people. So I think instead of being reactive and dealing with a crisis, we really have to step back and really looking at what can we do preventatively. Otherwise, we're just going to be in this washing machine cycle of constantly reacting and crisis reacting. We're dealing with COVID now, but South Africa has been dealing with different kinds of epidemics all the time. And we're just actually compounding on all of them. And I think again, back to the ground level, that a lot of people are not coping. A lot of people don't have hope, even if they speak to us or if they go to a clinic. They're still going back to their homes, to their abusive homes, to the no food on the table, to sick family members. I mean, it's really, really difficult. To end off my point, and it's something that our team has really been unpacking, and we keep this as part of our theme, and this comes to the late Desmond Tutu's amazing quote, where he says there comes a point where we need to stop just pulling people out of the river, and we need to go upstream and find out why they're falling in the first place. And I think if we're looking at how do we tackle suicide and how do we prevent these things from happening, is we really have to swim upstream and figure out how are we getting here and how do we prevent it. So I hope that's answered some of it, Rebecca, but I'm really looking forward to getting your details as well, to really continue the conversation. And I look forward to the chat box as well. Thanks, Santosh.
Thanks, Cassie. I see there's a couple of hands up, but before, I see there's 4 hands up and there's a couple of questions in the chat. So I'll leave my fellow panelists to engage with the chat room when you're not speaking. But Glynis, can I just bring you in before I get to some of the hands? Because I'm just wondering whether you have a perspective on this and whether you do cover some of this in your book, Waterboy. And I know certainly from the first panel discussion that we had, there was a lot of response to you sharing your own personal experience of losing your son to suicide. And I'm wondering whether, some of these more kind of larger structural issues are actually covered in some of your work. And I'm sure certainly in your journalism, they probably were covered.
In my journalism, more than the book, which was more a personal response, but also in dealing with the response to the book with people, it's the whole political background to so much, and the economic background to so much of what is depression in the end. You can't get away from that. So people would contact me through the book and then want to know where to get help, and you discover what situations they were living in, and it was almost impossible. I mean, even if they reached out to SADAG or whatever, they are still living in such terrible poverty, and they are battling so much to get jobs and to be able to find the meaning and self-respect and all those other things, and the self-confidence that one feels one needs to nurture if you want to see a point in living, if you want to carry on. How do they make those changes? It's like putting band-aids on people. It's very difficult. So, but then how do we make that kind of political, economic change, improving the quality of life, which is behind so much of this, without becoming, I suppose, political advocates or getting involved in the whole political scene more than the area that, say, Cassie is in, or the medical field. It's almost like another thing, and there are the civic organizations or structures that are trying to bring about change. Maybe one supports whatever they're trying to do to try to get some more equity and at least get people into decent housing and to have access to the proper health facilities that they need. I mean, we still got things like this life epidemic disgrace. It's not even a fiasco, it's an absolute disgrace going on. And until we can start addressing those things, we're not going to really make a difference. But I just don't know what one uses. Is that a political thing? Is it political parties and organizations? Whose work is that? For the rest, it's like Cassie said, we can offer up our words to the individuals that come to us and those words, but you're not changing the base structure. So it is very complicated.
Yeah, thanks, Glynis. I think that kind of last point about the base structure is a kind of nice metaphor, I suppose, because I mean, it speaks to a lot of the points that Rebecca and Cassie also made. I'm going to just move on to the hands that are patiently waiting in the chat so we can finally keep to my promise of hearing from the audience. And what I want to do is, I'm not going to kind of allow each panelist to respond individually to every question, but what I hope Rebecca, Cassie, and Glynis that you would do is maybe just kind of pick up on some of the themes that are coming up. And at certain junctures, I might just ask you to give a little bit of feedback, even if you don't respond to every individual question. Because that might take too long. And I was informed that Dr. Siepe and Saya Pierce-Jones, unfortunately, both of them are affected by load shedding and will not be able to join us today. So I do apologize on their behalf. One of the things we just have to live with in South Africa, unfortunately. Nontu, I know you had your hand patiently waiting, so I'll allow you to go first. Nontu Shongwe Makambeni, if you want to go, feel free. I think you have to unmute yourself first because everybody is automatically muted, I think, once they enter the chat. All right, we'll give Nontu a chance to unmute herself, and maybe we'll go to Aurora Brown. Aurora, you can go ahead.
Hi there. Yeah, I am a suicide survivor, and I completely agree with Rebecca and Cassie that, you know, this is something that needs to be addressed, I think, at the government level, because a big part of the problem or the shortfall is that there's not enough government funding in public hospitals to address all of the mental.
Aurora, I think you muted yourself by mistake.
Hi, okay, sorry about that. Yeah, because there isn't enough funding in the public hospitals. And I think part of the reason that, you know, the focus tends to be individualized in South Africa is because for mental health practitioners to consider the total population of everyone who's in need, it can sometimes feel a bit overwhelming, and it would almost make you feel defeated. So you focus on the person who's right in front of you because that's all that you can deal with. But unless it is structurally addressed from the government level, the problem is just going to keep snowballing as it has been doing up until this point. And so I think it needs to be made, I think mental health needs to be made a focus in the new NHI plans, because I mean, yes, that's a few years down the line, but any change like this is going to take some time anyway. And I think it also needs to form a real part of the public school curriculum, you know, mental health promotion. And perhaps the way to kind of get the government to take notice and take real action is to link it, to link mental health to the social inequality and racial inequality, because so often, you know, the social inequality and all of the factors that Rebecca and Cassie are talking about that are contributing to suicide and depression are also race-based in South Africa. And yeah, so maybe, that is something that is a priority to the government. So maybe by linking mental health to social and racial inequality, we can get them to take some real action.
Thanks, Aurora. I think it's a really important point. And I think, many critical psychologists in particular have written quite a lot about how, treating and preventing kind of mental health and mental illness and reducing social inequalities are actually part and parcel of the same endeavor. And I think it's really important that you highlight that point, and that we keep it at the forefront of our plans. And I'm glad you mentioned the NHI as well, because I think as we think about reconfiguring the mental health system in South Africa, we've got to make sure that kind of mental health is incorporated in a big way, so that we don't kind of fall by the wayside as usual, which happens with mental health. Ingrid Smith, you can go next. And if you don't mind just giving us kind of one sentence about who you are before you give us your comment or question, that'll be great. Ingrid, you can go ahead. Don't forget to unmute yourself. All right, we'll move on to Nobanzi Dlamini.
Hello.
Hi, you can hear
you. Hi, everybody. Thank you so much for this session. I feel it's very, very important and quite relevant to all of us, because anyone can, fall victim to this situation. I'm a mental health advocate, even though I work for immigration services. And my question, or maybe should I say my input, would be, how about we explore introducing all this talk about mental health in our communities? For example, I'll just make an example with an African community. For example, we have, when our children are growing up, there is traditional cultures that they are, introduced to say, when you're a girl, this is what happens, or when you're a boy, this is what happens, this is how you grow up, this is how you stand up for yourself, this is how you show you're a man or a woman, and stuff like that. I know that in most cases, it's all about how you will navigate life in your social settings. And I don't think we ever go as far as saying, as you grow up, what challenges will you face and how will you face them? And if they should overwhelm you, how would you handle them? Or would you be able to come back to the community, or would you be able to come back to the traditional leaders or cultural leaders in our different cultures? Because we have quite a number of cultures in South Africa, to say, let's open up from the traditional perspective or the cultural perspective, to say, let's talk about it from when the children are growing up. And also, I think we need to get to a point where government recognizes mental health as part of the curriculum. There's just no way we can avoid learning about mental health from a very tender age, because clearly what we're seeing now is a result of not being exposed enough to information about mental health and information about how to deal with mental health issues. Thank you.
Thanks, Nobanzi. I think you raised some important points there. And I always find it tricky, this issue of awareness, because, on the one hand, and maybe it's just because I'm so involved in mental health and I'm a psychologist, I kind of feel there's like so much of awareness, almost like kind of hyper awareness. You can't open a single magazine, newspaper, go onto a single website today without finding something about mental health. So on the one hand, I feel there's an information explosion around mental health. Every second celebrity seems to be coming out with the mental health diagnosis. But on the other hand, there's this kind of tension between all this awareness, but then this lack of access, But again, even the debate about the lack of access is again predicated on this individualized approach that individuals must get access to individual mental health care. So, even that can be quite problematic in some sense. So I think there's a couple of tensions there that perhaps need to be properly teased out as well. But thanks, Nubanzi. I think you raised some important points for discussion. Anna Mabina, go ahead. And please feel free to tell us who you are and where you are from.
Good evening, colleagues. I hope I am unmuted.
Yes.
Yes, my name is Anna Mavina. I'm a mental health practitioner. I'm working at a tertiary institution in a rural area, in a rural place, in a rural province. I just want to share my frustration, based on the discussion that we're having tonight, that, my assumption is that 5 out of 10 students who come, I work in a center for student counseling and development. So 5 out of 10 students who come to the center for psychological intervention, they present with suicidal ideation. Some have attempted. But then the frustration that I want to share with you is that we have a hospital within the town, in the township. The psychiatrist comes once a week, and immediately when we encounter a case of a client who is suicidal, we have the system in place. We have the protection service, we have the ambulances, then we will write a referral letter and refer the client to the hospital. But then this client will come back the same day, and then they will report that they were not attended to, because there was no psychiatrist, there was no psychologist, there was no one to just attend to them. And the client who was suicidal, who stays alone in a room, has to come back and go back to the same room with all the triggers and all the challenges that they are facing. Nothing has changed. And you send the client to the hospital for evaluation, for intervention, for assessment, so that the client is attended to. So my frustration is that, what do we do in this kind of a situation? And I want to agree with Casey when you said the system fails us. And you said that sometimes there are resources within the system, but you know what? It is not happening on the ground. And that is our frustration, that we are losing students. We are losing students through suicide because of, the psychosocial problems, because of poor academic performance, and, other socioeconomic factors that we really, that they are really experiencing. So it is our daily frustration dealing with students who will come back from hospital without being attended to. They are given a date to come back to the hospital after a week. And, I remember in the previous session, Dr. Sebe spoke about, clients being in control. But then how do you really help the client to be in control when the client goes to the hospital where they think, they will be attended to? They have to come back, and really it's frustrating. So I just want to share this frustration and say, I wonder how can we really help the students who are parasuicidal. Thank you so much.
Yeah, thank you. And I think, again, such big problems, I think it can feel overwhelming. And I'm sure everybody in the audience can probably share at least one story where they probably just so incredibly frustrated at how the system kind of keeps failing people. And we keep talking about the system. And I suppose one of the things that maybe I want to put to the panelists, but also to the audience, is that, when we talk about the system can almost seem like something that's outside of us, when in fact we are all part and parcel of the system. And we all kind of implicated in electing people who are part of that system. And in many ways, we keep these kinds of systems going, either by kind of omission or by commission or whatever. And many people in the audience, are part of these kinds of spaces, where there's possibilities to create change. But even when you're inside a system, and even where you might feel like you're in a position of power, it can often seem like you kind of railing against something that's so much bigger than all of us. I don't see any more hands up in the chat, so maybe I can put this back to the panelists. Is how do you, as an individual, but also as a person in your own professional space, kind of conceptualize the system? So when you think about the system, kind of where do you see your own role in that kind of space? Glynis, do you mind if I start with you? You're on mute, Glynis.
Again, it comes down, because I happen to be a journalist, trying to raise awareness, and it comes down to education. And so I'm also trying to do what I know SADC, I think, does too, is to get into schools and speak to people there. I was doing one talk on Saturday, and again, the idea that it's got to be introduced in the schools. It can't just be odd people going and giving talks. So how about them including something like mental health, wellness, or whatever in the LO syllabus? We need to get it into some kind of formal setting where people, whether the children end up doing role play or whatever, and dealing with feelings and expressing themselves and understanding other people's emotions, being able to recognize needs for help and how to give support and all that sort of thing. It's not going to, again, obviously address people's living conditions and the socioeconomic and political problems in this country, but those are almost in another field at this stage. But if we could start by just getting mental health into official school space, like LO or something. I know also that SADC are into universities, and they've got their own specific call centers and things centered on those. Cassie can pick up on that, so that would help there. But again, in some way to involve the students and get them to be exposed to more information that could be useful to them.
Yeah, thanks, Glynis. I'd like to share some experiences I also had with working with schools, but I see Francesca Chetwin's hands up in the chat. So let me just get her comment or question first. Francesca, go ahead.
Hi there. So I'm a Johannesburg-based psychologist, and I'm just enrolled in a PhD at WITS at the moment, rolling out an attachment-aware schools program in a small Johannesburg low-fee school. So the fundamental principles of the attachment-aware schools program is that we work with teachers around being able to engage with children around emotion. And, the school system around the world remains highly behavioral, that, emotions are not important, but we all know as mental health professionals and human beings that emotions and learning are fundamentally intertwined. So my hope, my great ambitious hope, is that my PhD will provide an evidence base that an attachment-aware schools program has a place in South African schools. And that's about working with teachers using a listening emotion coaching model, which is, the attachment-aware schools originated in the UK, but really it's appropriate around the world because it's about emotional listening and identifying vulnerable children and applying a very simple listening process with children and being able to understand and for vulnerable children in particular, create a space and slowly but surely build a feeling of safety and trust and a more, I suppose, mirroring the kind of qualities that we have in a secure attachment. So I'm just about to start fieldwork tomorrow, in fact, in a school in Mayfair called Salvazione School. And I'm hoping that my PhD and the results of it will provide an evidence base for training in general. There are also 2 private schools that have gone live with programs, which is very encouraging. So it's starting small, but I'm really hoping, and it isn't about, intervening in LO or, it's about really empowering teachers to listen in a particular way And it's not complicated. But of course, we know that for many people, these are not experiences they've had themselves. So I suppose, yeah, I'm trying to do it in a nutshell, but that's my hope, my deep, deep hope, that this program will grow wings in South African schools.
Thanks, Francisca. Good luck with your PhD, and thank you for just sharing that example, because it kind of speaks to something I was going to mention just now, but I'll just put this question out there for everybody, because I am an optimist by nature. And that is, I would love to hear examples of what is working, however small, in however tiny your context, because I do believe we've got to build on things that are already working in some way, even in a small way. And that little example that you shared, that you're doing with your PhD, I think is an excellent example of that. And I think, one of my colleagues, her famous phrase that she always quotes is, "Don't curse the darkness, light a candle." And I love that phrase, because I think it's so easy, and we could spend all night until midnight lamenting the problems in mental health, lamenting the struggles. And as someone like myself, I've worked in the public hospital system for over 10 years. The phrase overworked and under-resourced has become almost like a mantra. They should just put it on the front of every hospital before you enter. But I refuse to buy into that mentality. Because I think it's so important that whatever system or context or space we find ourselves in, that we've got to find ways in which we can be innovative and imaginative. Because there is no country in the world that has overcome its systemic structural issues. So it's not like there's a utopia that's waiting for us to achieve. And I think all of us have to find ways to kind of balance the lamenting with also the kind of imagination and the doing. So I think that's also quite important. So thank you, Francisca, for just sharing a real good example of doing and how you're doing differently within your context. Eugene, I see your hands up, and I know you also posted some really interesting comments in the chat as well, but go ahead.
Hi, good evening. Can you hear me?
Yes, loud and clear, Eugene.
Okay. Hi, thanks for the chat and really the panel. I think I am a clinical psychologist, a community service, doing my community service in Northern Cape. And I think what I've experienced, the frustration with the system is that, when you only have like 15 patients and you need to do a risk assessment and you only can access 5 of them. And the frustration is that you have to send them back home, and I think also because we are so few, even if we're selected for master's program, we are so few in the field also. And I think also it's the frustration as a psychologist, fighting the system or kind of being an advocate in the system itself. With a parasuicide, when you hear comments like doctors or medical people will say, or professionals will say, no, they're seeking attention, they're not for real. So I think in that part also, you being an advocate, fighting in the system itself is also frustrating. And I think this is the things that we as practitioners working in the field that we kind of also, I think, struggling with. And it's a challenge. It's really a challenge. But I think these are the type of panels that we need, not with psychologists also or researchers, but also with medical professionals, and to broaden this perspective to talk about it. Thanks.
Thanks so much, Eugene. Eugene, you also raised an interesting point in the chat, which I actually wanted to revisit, which was the issue of training programs and how many psychologists, for example, are selecting to master's programs, and then how most of them then go into private practice. And you made an interesting point, which is that a very small percentage will work on the ground. And I suppose it's often seen that if you're in private practice, you're kind of not working on the ground. But certainly, given that the majority of mental health professionals are in private practice, and I imagine that they're seeing real people in this country as well, that those people also exist on the ground, as it were, but perhaps in a different class structure compared to the people like myself might be seeing in the public hospital system. So I think that issue raises, number one, who we training, but it also raises the issue of how we training people. Are we training people in a way that actually allows them to deal with these systemic issues that we're all talking about right now? Or are we simply training psychiatrists, psychologists, social workers, occupational therapists to actually only deal with individuals? Or at most with small groups, maybe like a support group or group therapy, for example. But perhaps part of the difficulty is that by default, our training is actually disabling in a way, in that it doesn't allow us to think quite systemically. So we can all recite maybe, I don't know, Bronfenbrenner and talk about the macro system and the meso system and all of those things. But when it comes to the actual doing again, we perhaps struggle with that a little bit. Rebecca, do you mind if I bring you in and maybe just to comment on that, issues around training and whether you've got any thoughts about that?
Sure, Santosh. I mean, I can share my personal experience. I wanted to be a clinical psychologist. I worked for a year between honors and masters on the Cape Flats. I saw 25 children a week, and I sent them back home every day, back into the community. And I just thought, I can't do this. I want to do something else. And then I became, I carried on and I did research, and that also breaks my heart, but in a sort of different way. But I was thinking, so yeah, I do think there's an issue with training. I don't deny that people are doing great work and there are lots of professionals, but also to have to carry that and to have the feelings, of having all these people come through your door and to feel like you can't do something, or you can't do enough, that is also like a really big problem. And I see lots of people posting in the group about what does it mean to be a mental health professional, to be, to be a doctor in this context. And so there's also a lot of distress being produced within the system, which I think is really important. But I guess one of the other sort of central ways of thinking about suicide prevention in a more critical way is thinking about issues around belonging. And there's a lot of sort of interesting work by people who I guess would say that they're sort of critical suicidologists. And one particular woman called Vicki Reynolds, who works in Canada, and she talks about suicide as a result of unbelonging. And we know that there are all sorts of patterns among young people, particularly people who are LGBTQ+, and issues around, various kinds of social exclusion. So I think to think about suicide prevention beyond the context of just within the individual, we can think about what are other social structures that can create sense of belonging. And I like the example about the school and creating programs and other spaces for young people to sort of come together, because those are some of the things that can make life feel more livable, perhaps in more sort of long-term ways. And I heard other people making reference to, the role of, churches and other organizations like that. And I think those are things which are already happening. And unfortunately, some of those things are happening because government is not, and then other people are stepping in to fill those gaps. So I think there's a balance that needs to be struck there around accountability and about whose job it is to do what. But at the same time, that there are other structures which, other groups, other programs, other approaches, which are working against sort of distress and alienation and stuff like that. And it's also important to connect with those.
Yeah, absolutely. Thanks, Rebecca. Cassie, I wanted to just link with what Rebecca was talking about also, because one of the things that was coming to my mind that SADC has done really well is that you guys have been able to attract, but also identify individuals who through their own experiences have become kind of big advocates for mental health. I'm thinking of, for example, more recently of people like Henry Koch, who through his own mental distress of losing his business during COVID, ended up running halfway across the country, breaking a Guinness World Record, raising a whole bunch of money for SADC and mental health. And I'm sure you've got like an endless black book of names of people who started off as someone in distress and reached out to SADC and then ended up becoming almost a household name. So in some way, I think you guys have a good knack of getting people to become mental health advocates that either directly or indirectly end up challenging the system at a broader level. Do you mind just sharing some of those kinds of lessons or experiences around that?
No, absolutely. And thank you for that. And I think, it's also really important from SADAG started from a lived experience perspective. So having the voice of people who've been there, done that, got the t-shirt is really important. And I think, we can stand on all the soapboxes and talk about, I saw a lot of comments in the chat box, like the information and the awareness, and we've got that. But hearing from people who can share their experience and their journey, I think it's also really important in sharing hope, which we need so much, and especially during these times and when people are dealing with really difficult situations, is to let them know that there is some hope, and not false hope, but really working on, this is what worked for me, maybe it'll work for you, this is what I've been through. And I think it's having those real experiences, whether it's someone from your community, from your church, or someone who's on a public platform or a social media influencer. We have to look at all these different spaces, and again, there's so many people who can share. So for us, it's really important to give a voice to that lived experience, as well as to share some of that hope. And I think for a lot of people, they need to hear that there are options and that they can try this. Or, I think it's also to see proof, right, that this person has got through and that they've been able to make a success, or they've been able to do something and get the help. So we've been very, very lucky. We've worked with amazing people who do these supernatural things of running a ridiculous amount of marathons across the country. But there's also something to be said, and I saw the topic coming a lot up in the chat box and the Q&A, the role of culture. Having someone who stands up in their church and says, but I'm depressed, and this is what I've been through, and this is my journey, and this is my treatment. That's a huge advocate for mental health, because it really challenging that status quo, how culture sees it. Having someone, and I saw in the Q&A box, someone share their own living with bipolar and depression and thoughts of suicide with their family, who's coming from an African culture, who doesn't see it as a real illness, who doesn't know how to support it. And we often get that, where they say, don't take the medication, or don't go for the treatment, or don't do this. And I think, having someone who advocates for themselves in their communities, in their families, are just as valuable and important as the person who's running world record breaking marathons. And I think we need to share more of those stories and those lived experience. And unfortunately, sometimes the narrative around mental health is all the negative stories that are printed, that we're reading, of celebrities who die by suicide, or hotspots in certain areas. And I'd love to even rack Rebecca's brain around, from a perspective of reporting on suicide and reporting hotspots and some of the details that we often find in the press and media or on social media. But I think having that lived experience and having those ambassadors, whether it be professionals or person in their community, is really important and really valuable. I also just wanted to touch on, Santosh, some of the questions that, in the comments that were being made, and kind of linking to all of this as well, is, both from a policy perspective, and I loved what Aurora was saying about, we need to get government, we need to get these policies in place, we have to involve it in the NHI. And I think, from perhaps my cynical point of view at the moment, is that, yes, those policies are important. And again, we can come back to South Africa has very good policies in paper. We have the Mental Health Care Act, we have the strategic framework. These are really good documents on paper, and they're better than some of the other countries across the world. And I saw that comparison, and Rebecca, about comparing our data to other countries and how did they do it and we don't. And there's 1,002 different factors, which is why mental health and suicide is so complex, but so fascinating, is we've got good policies. But the real need is we don't have the time or the resources to have amazing policies in place. Is we actually have to see what we already have and what has taken a long time to be put in place to be implemented on the ground, so that if you're working in a district or at a clinic or in charge of a provincial department, have they been made a fay or trained or worked with these policies? Are they implementing it? Are they reporting? Is there monitoring on it? So I'm a bit skeptical about more policies. I just see long time periods, great things on paper, but not being implemented on the ground, which is often the issue we have with mental health in South Africa. So that would be my sense. and again, kind of throwing this back to Rebecca on the issue that we as South Africa don't have a suicide prevention strategy or suicide prevention policy in place. And if you would think, Rebecca, that would be something that we should be working towards getting something in paper, would that see a change in how we advocate to government or to communities or to schools or to universities? Yeah, I'd love your thoughts around that. So I hope I answered some of those questions that you wanted, Santosh, and hopefully I can throw it back to Rebecca as well. Thank you.
Yeah, Rebecca, respond.
Thanks, Santosh, and thanks, Cassie. Yeah, I think this thing about suicide prevention strategy is really interesting. So I'm currently based in Scotland, and they are currently in the process of developing a new suicide prevention strategy. And so I've been involved in various public consultations and stuff like that, which has been really interesting. And there is an interesting shift to including lived experience and all sorts of things like that. But I guess, and I was meeting with an organization in India recently, and they were talking about the fact that there's a lack of such a national suicide prevention policy there. I guess my concern is, and in my work, so firstly, the things that you mentioned, Cassie, about then what happens to that policy and how do we implement it, but also about this, desire to have this one-size-fits-all understanding of suicide and why it's happening. And I see lots of people in the chat were mentioning stuff in relation to different dimensions of culture. And our research project is actually called Suicide Cultures. And we're really, from a sort of social perspective, looking at how people understand suicide in very particular locations and what are both the sort of local and global factors that are influencing the way people experience suicide, the way people perhaps practice or experiment with suicide, the way people understand suicide bereavement. So I think there's always a balance to be struck between the sort of, the global and the local, which is also why there's sometimes this breakdown where we see a program that may be working very well in a specific context. And which is also why these community-based sort of interventions that are doing specific things in specific communities are really important. So I do think that, also the work of putting together a national suicide prevention policy can be useful in itself, because it brings people together, it brings, government into the conversation and stuff like that. But I think that there are all sorts of local issues and struggles and things which perhaps also need to be addressed in other ways.
Absolutely. And Cassie, I'm kind of with you when I hear about more policy. Given the high hopes we had in 2012 when they developed the National Mental Health Policy Framework in South Africa, and the consultative process that went into that, going to every province and getting input from everybody under the sun, and this nice shiny green document that I think we all have in our offices that has quite literally collected dust, is such a waste. And I personally have absolutely no hope for the updated version of the policy whatsoever, because I think without trying to be facetious in any way, I think the South African government has shown quite clearly that it has no commitment to implementing any sort of policy in this country, however well written it is. And we are beautiful policy writers, but we just can't get implementation right. And I wonder why that is. Glynis, I saw you kind of shaking your head, and I wonder when you listen to some of the discussions happening over here, how does it resonate with you? Because for you, this is not theoretical or abstract; it's deeply personal.
It's deeply personal. That's in fact the only level that I feel qualified to really talk on and deal with, other than through my writing. I don't know how one works. I, in my own small way, can only reach out and share my story and do it on that basis and resonate with other people's truths and get that through, to get people from different cultures maybe talking together at various ways. I mean, and going out to other communities and getting other people to do that too. It's a very difficult one. I mean, I can only see it on a small scale, but you guys who are the professionals need to look at the longer range and the wider scope. But from the the journalist point of view, even I just imagine one more policy, as you say, gathering dust on the shelf. There's just so much of that already. To me, it's the personal hands going out that are going to make more of a difference.
Yeah, thanks, Glynis. I want to throw a question out to the audience, and I hope there'll be one or two brave souls that try to answer this. But there's this question of culture that's repeatedly coming up in the chat and in the Q&A. And the one comment that really stood out for me was this idea of suicide being taboo. And so even when someone attempts suicide or dies by suicide, that families in particular cultures might even deny that it was suicide. And they may know from a kind of cultural perspective, people might even have beliefs that bad things might happen to either the person in whatever afterlife is believed in. And so that really speaks very tangibly to the issue of destigmatizing suicide, because it's linked so intimately to kind of cultural beliefs. So I would like to get some perspective from people about that. You know, how do we do the work of destigmatizing suicide while at the same time taking very seriously some of the cultural issues that people might have about owning up to the fact that in fact there is a suicide or a suicide attempt within the family system. And I saw one hand go up and then go down very quickly. So whoever that was, feel free to kind of contribute to the conversation as well. Nubanzi, I see your hands up, so go ahead.
Hi, I'm not sure if you guys can hear me.
We can.
Okay, so for me, and I'm not sure if I'm gonna be answering the question or it remains a question from my side. I'm looking from a culture, an African perspective of a Black person, for example, a Black person who falls sick and might present maybe symptoms of bipolar. But from the African perspective, it looks like they've been bewitched, you know. It's difficult to convince the family to take this person to the doctor because they believe in the other, you know, the bewitchment, or there's someone who's after the family, or there's a curse and stuff. So I'm not sure if in the near future we would be able to tie in the African traditional way of treating people who have or are presenting with mental illnesses that are already on the DSM-5. We can already say this one is presenting with symptoms of ABC, and therefore maybe we're going to treat them with ABC. So I think it's a matter of tying in the African perspective of mental sickness and the Western perspective, and just trying to see how they can work together, because there's times where you can see that this person really needs to go to a mental health facility, but because of our African belief system and many other, you know, I don't know, ideas that we have around it, we don't go to the doctors. Yeah, I don't know. Basically, what I'm trying to say is we need to find a balance between the African perspective and the Western perspective so that we can find some sort of a solution. I know it won't be, you know, a holistic solution, but at least it ties in both ends of, you know, the perspective, the African and the Western perspective. Thank you.
Thanks, Nubanzi. And I see Amanda Zulu in the chat also said loves the idea of working with the African and Western perspectives. Nicolette, can I hear from you?
Hi, yes, can everybody hear me?
Yes, we can.
Okay, so I am a counseling psychologist and I work at a university where I find I work with student population. And what I usually do with the previous lady that just commented is that I usually put in the Western and traditional together. So you need to explore, you know, what are a person's beliefs, and then usually they'll share that, you know, I go to a traditional healer, or this is my option. And because we usually have to, not usually, but we have to respect what the client presents with, their beliefs. So usually it's a very important question to ask. And usually what I do is that I usually then would ask, let us try different routes. Let us try the spiritual or traditional route, and then usually they are more open if they've tried that, and then we go to the medical side and then they try that. Even families are usually more open to that idea, just feeling like, okay, but we are not dismissed, our beliefs are not being dismissed. Therefore, they become more receptive and open. So I think it's very important for us to continue, teaching our African traditional families as well, about mental health. And it's a very, I think we are on the right track, and I'm trying to stay positive. I think we are definitely in the right track. So that's just what I wanted to say. Thank you.
Thank you, Nicolette. Sounding optimistic. And I see Pindile Kumalo also makes a nice point in the chat, linking to, I think, Rebecca's earlier comments about kind of unbelonging, and how traditional healers also believe that suicide happens as a lack of connection with ancestors and society, which is very much like the lack of belonging in Western literature, and so that we don't have to exclusively look at an either or paradigm. And in fact, there might actually be some synergy between both. Aurora, I see your hands up.
Hi. I'm not from an African culture. I was raised in the Christian paradigm, so I'm not going to try and talk to the African paradigm. But even in Christianity, in certain denominations, there is a stigma around suicide, and it is very looked down upon. And I think if I can just emphasize what the previous speakers were saying, you have to work within the client's paradigm. And I think it's important to emphasize that it's not about denying their beliefs or necessarily changing them. It's about finding a way to work within that and linking the medical understanding of mental health, or the psychological understanding of mental health, with something that is already existing within their belief structure.
Yeah, thanks, Aurora. I think that's a really important point. And we know in South Africa, we are kind of cultural melting pot. So when we speak about culture, we're not speaking about one thing. And, we're speaking about so many intersecting beliefs, both within families, within communities, across communities. So we're in such a kind of intercultural, multicultural, diverse kind of system itself, that culture in itself becomes a whole conversation. I imagine we can have a whole conversation just on culture and suicide, which would be quite fascinating. Not that I'm volunteering for a third webinar, Fatima, so please. Mfundo, I will give you the last opportunity to ask the last question, and then I'm going to just round up with each of the panelists. So go ahead, Mfundo.
Okay, hi. So I'm Mfundo, I'm based in Alberton. I think I only have my honors in psychological counseling, and within the church community, I think those that know of my qualification tend to use me. So just recently I had a talk on mental health and suicide within the church context, because I think, people have a longing for this information, whether it's African culture or in the church context. I think with where we are at now, everyone really is starting to think of mental health, and we just need to find a way to incorporate it within culture or within our religious context. And I really, having a talk in the church setting, and you have people that, to make them understand that, in as much as you can take care of your physical needs, how it doesn't matter which background you come from, we all take care of ourselves physically with our health. We talk about diabetes, hypertension, it's things that Black people relate to, Christians relate to, because we have these things physically. So to introduce mental health in that way, to say, if we can take care of these things, mental health needs to be taken care of in the same way. And I think you're just bringing it that much closer to them, and it becomes something that's personal and not something that's just seen as, I don't know, it's just separate from them, or it's for a certain race, or it's just not African. But when you bring it to, if you do get flu as an African person, so why is it difficult for us to understand that, someone can suffer from suicidal ideation or anything, or something along those lines. So I think also in just how we presented, knowing the kind of audience that you will be talking to, and really, I guess it goes back to the point of context, contextualizing. Even when as you are presenting to the people, you must bring it closer to home so that it makes sense and it speaks to their need. And I think we even had a breakthrough in that church where we had one lady. She actually said, I have so I've attempted suicide, and now she was speaking in the church. And it's someone that I was there it was my first time in that space, and it's someone they church with every single weekend. They know this lady. I don't, but that day she actually said, listen, I've been coming here, these people don't know my story, but I've attempted suicide more than once. I've been diagnosed with bipolar. And everyone, well, they didn't give her this judgmental look, but everyone was so shocked that we literally with you every day. You are a Christian, you're one of us, we pray together, but we didn't even know that much. And I guess it opened up everyone's minds to say, listen, these are conversations we need to start having. And this is something that is so real, even in this, in the church community. So I guess it's just how we also as mental health advocates present it and really contextualize mental health. Thank you.
Thanks, Mfundo. I think that's a great final kind of comment, because context is everything. Context is everything. Carl, I see your hands up, so I'm going to just make an exception and squeeze you in. If you can make it really short, because we want to definitely end at 7:30 on the dot. Carl, you can have the last comment.
Am I unmuted? Can you hear me?
Yes, we can hear you.
Oh, okay, thank you for the opportunity. I'm a retired industrial psychologist. I've been in academics for most of my time. I need to sort of put together, Rebecca talked about the issue of suicide prevention issues. And earlier on, we talked also about the issue of training. Well, as an old psychologist, I'm aware in the South African, we have worked with HPCSA in a lot of issues. We need to put in mental health in all the psychologist programs, clinical, it's in clinical and mostly in counseling. In industrial psychology, people are not into these issues. And we need to sort of come up with a program that also addresses wellness and mental health, even in industrial psychology. Now, my background, fortunately, is that I did my master's in the US. So I'm very grounded in psychology more than industrial psychology. South Africa is so silo-oriented. A lot of issues, we always say, leave that to clinical and also to counseling. It's not your work as an industrial person to talk about mental health issues. But one of the issues that the lady raised, I was teaching in rural universities. Even my last university was rural, 3 Black-oriented universities, as I may say. The facilities are there, but the programs are not used. I went through a difficult time last year when, when COVID has an impact on both lecturers and also on students. Students don't do their work. They don't attend. There was a time when I was angry, imagine, for the first time. Like my last 4 months in academics, I get angry with my honor students. And one way of getting out of that, because I told them where to get off, and I was unfortunately live. And I had to take a shortcut, go to a psychiatric hospital in the Centurion area. I'm not going to mention that area. The issue that I realized is the importance of mental illness, mental health. It came to me as a psychologist that how many South Africans are suffering out of this. Now, the issue about this hospital, it's meant for people who have money. It cost me almost 50,000 to stay there for about 3 to 4 weeks. Now, most of the people who were there were students, were the elderly. They suffered from different issues. Some of the people who came, I'm just making an example because I've been to Limpopo, had witchcraft-related issues. And then when I suddenly learned that if you believe in good spirits, there must also be evil spirits, okay? And I changed my perspective, and I saw that it's becoming very important in our training, even at universities, especially during COVID. A lot of teaching, even in high schools, people are going through mental issues. We have no programs. We are not even taking care of what students are going through when they are working from home. They always complain about networks, and they'll complain about data, but there are other issues that stresses them. Not being able to work at home, we are not used to that. So training has to be sort of visited so that at least there must be short courses on mental health for all academic teachers, for all even lecturers. People need to know and understand how to spot students who are experiencing mental health issues, students who may be suicidal in their issues. But lived experience taught me a lot. Now I'm going home to Bloemfontein, that's a wellness center.
Sorry, Carl. I'm going to have to just cut you a little bit short because we.
Okay, Chair. Thank you.
But thank you for your contribution. And I think you've raised an important issue. And I think that lived experience perspective is something that we definitely have to keep coming back to, because it enables all of us to kind of ground the conversation in real experiences. I'm sorry to cut you short, but I want to just also respect the time of all the panelists and the audience members. And thank you very much for sharing your perspective from the other side of retirement. Some of us are very, very far from there. So definitely appreciate your contribution very much. Thank you everybody for staying the course and being with us for the full 90 minutes. I see it's only in the last minute or two that we've had people leave as they can. Thank you, Glynis. Thank you, Cassie. Thank you, Rebecca. I'll just give you maybe 30 seconds or so just for some final concluding comments. Glynis, if you can start with you.
I should just carry on sharing my own personal story, because to me, when you speak from your heart, other people open up, and it's all different cultures that respond, and that's all that matters. Yeah, and I shall just carry on doing that. And just, I think what you said is important. We need to hold on to and try and spread hope. Thank you, Santosh.
Thank you, Glynis. You're doing amazing work just by sharing your story. Thank you so much. Rebecca?
Thanks, everyone. Yeah, it's been great. And thanks for everyone for sharing their perspectives. I guess just to round off some of the things that people were saying, I think that maybe some of these issues around stigma and not talking about mental health could be challenged if we change the way we think about mental health as related to all these, political and social inequalities. And they're produced by the fact that life is difficult and life is challenging. And, that there's racism and homophobia and poverty and that kind of thing. And so maybe if we shift to thinking about more sort of social political understandings of mental health, and obviously that's also related to suicide, we can move beyond this thing of thinking that it's something that's wrong with the individual and people are not coping as if it's not normal to not be coping in this completely abnormal society in which we live.
Thanks, Rebecca. If you don't mind posting a link to maybe the suicide cultures work that you're doing, that'll be useful. And Cassie, I'll give you the final word as we wrap up.
Sure, thank you. And Santosh, I'd love to throw that challenge back to you, is that we can't stop the conversation now, and there's so much to unpack and so much to talk about. And I really would love to encourage people to even start these conversations in all the communities that they're working on, all the projects that they're doing. And I'd love for there to be a network or a platform where everyone could share what they're doing, because I think that we learn and we work together, because as you mentioned, we are the system. And we need all of these people within the system to make a difference. I think my lasting words is that, we're dealing with this mental health pandemic, the suicide pandemic. And my only wish is that imagine if we dealt with this mental health pandemic and the suicide pandemic as we have with COVID. and everyone could work collaboratively, and there's this national crisis and we had this plan, that's where we should see mental health, and that's where we should see suicide. I think for often speaking for myself and all the other amazing people that are working in their communities, in their spaces where they're helping to advocate for mental health, is as much as a lot of this can be quite doom and gloom and discouraging, it's just about remembering that we are part of this bigger system, and that not to give up hope, because talking until someone listens is really important. And we can only do that together. So thank you for the platform. I look forward to more discussions and learning from others. And I think this is a step in the right direction. So thank you.
Thank you, Cassie. Thank you, Glynis. Thank you, Rebecca. Thank you, Cassie. Thank you to Fatima and Muhammad in the background who've been assisting, and to the PsySSA office for initiating this important dialogue and for doing great work under difficult circumstances. And thank you to everybody for attending, because I, for one, was very surprised by the high number of attendees, both for the first and the second panel. But I think given that we had such a rich interaction, I can definitely see that there are so many issues across the board that still require so much unpacking. And I'm pretty sure if we do another one, we'll get a equally responsive engagement from people across the country. So thank you everybody for making the time to have this conversation. And yeah, I think Cassie's challenge, if each one can go on and have this conversation with another group of people, we could have 140 other conversations across the world. And we know that conversations can change the world. So yeah, here's a challenge to everybody. If you can just take this conversation further, even if it's to your workspace or your family space tomorrow, I think we could do amazing work. And yes, this will be recorded. It is recorded, and it will be posted on the PsySSA website in the coming week or two. So if you want to share it with others who weren't able to attend tonight, it definitely will be available. And thank you to everybody who posted such rich commentary in the chat room as well. And sorry that I didn't read everyone out, but I'm sure that people did read them and engage with them in some way. So thank you, everyone. Have a lovely evening and a good week further.